Good afternoon, brothers and sisters, ladies and gentlemen. Welcome to this webinar on Living and Dying with COVID, jointly organized by Pa-Auk Meditation Center, Buddhist Fellowship, Dot Connections, Palelai Buddhist Temple, and Ruan Buddhist Society. COVID-19 has landed in Singapore since February 2020. Since then, Singapore has done a remarkable job at keeping our number of infections and deaths relatively low compared to many countries in the region and beyond. And now we are moving towards preparing for living with COVID-19, and restrictions are being progressively lifted. But in recent weeks, we are seeing a surge in both infection and death rates despite rising vaccination rates across all eligible age groups of Singapore residents. Based on the announcement from MOH last night, we have seen 18 deaths in just August alone, and that is about 1/3 of all deaths recorded since the start of the pandemic more than 18 months ago. There may be many questions on your mind. Are our vaccines effective? Will they be effective against newer variants like Delta and Lambda? What happens if I and my family become the next to be infected? What more can we do to protect and prepare the frail and the vulnerable among us? These are pressing questions that we hope to have clear answers through our webinar today. We are extremely grateful to have Professor David Lai, an eminent clinician and researcher at the NCID, to speak on the topic of vaccination, COVID vaccination, the truths, the myths, and the urgency, and to have Dr. Neo Han Yi, which will be touching on an alternate reality that the public often do not see. That is the lonesome death of dying with COVID-19. In his talk titled, "What is so important to know about dying in the era of COVID?" So thank you very much, Professor Lai and Dr. Neo, for kindly accepting our invitation to speak. Each of the speakers will speak for about 15 to 20 minutes, after which there will be a Q&A session for about an hour to further clarify our doubts. We have already received quite a few submitted questions prior to this webinar. In the interest of time, there will be no direct posing of questions to the speakers. If you have any questions for the speakers, please type them in the chat box. We will collate and raise them as best we can during the Q&A session later. Without further ado, let me now introduce our first speaker for today. Professor David Lai currently holds the position of Senior Consultant in the Department of Infectious Diseases in Tan Tock Seng Hospital. He is also the Associate Professor at Yong Lu Lin School of Medicine, the National University of Singapore, as well as the Associate Professor at the Lee Kong Chian School of Medicine. At the National Center for Infectious Diseases, Professor Lai is the Director of the Infectious Disease Research and Training Office. Professor Lai is an eminent researcher scientist. To date, he has held more than $10 million in research grant as principal investigator and has published more than 240 peer-reviewed papers in top international medical journals, including the Lancet, Journal of American Medical Association, as well as the New England Journal of Medicine. We are very fortunate indeed that Professor Lai has kindly accepted our invitation to speak on this topic, COVID vaccination, the truths, the myths, and the urgency. Professor Lai, please.
Good afternoon. Thank you very much for the kind introduction. So this is a critical point for the whole society to get ready for the next phase of our COVID journey. So I'm very happy to talk to you, and hopefully we'll answer some questions. Okay, move forward. So now, what are we facing with COVID-19? A lot of people will say COVID is very mild, I don't worry about it. And in some way they are right. The majority of people, about 30–40%, have no symptoms, and then 20–30% very mild, just a sniffle. But the truth is that even in this setting, you're equally infectious and can transmit to your family, your colleagues, your neighbors, and your friends. Now, severe disease requiring oxygen, this is the one that we are afraid. At least from in the unvaccinated patients, it is age dependent. So I'll talk about effective age later. But in general, overall, you're looking at about 10 to 15% of people may need oxygen, but it is lower when you're young, and is higher risk when you're older. Okay, and you may have read about how they run out of oxygen in India in early part of this year, and then for a small number of people, they couldn't cope with just being given oxygen and other treatment, and they need to go and do the intensive care. A machine helps them breathe, and they have a lot of tubes and needles put into them to support their bodily function. And that is about, overall, in Singapore, it's a bit less, it's about 5%. Now, the overall mortality rate, if you look at the worldwide data, is about 1 to 2%. So it's definitely not the flu. A lot of people online, some people online will tell you it's just a flu. It is not the flu. Singapore, we have done very well in keeping the death to a low number. Is partly because last year there was not a lot of community transmission. It was mainly in the dorms, and most of the migrant workers are young. And this year's, you notice there are more deaths because this year is mainly community transmission. And in some of the big cluster recently, Bukit Merah, the wet markets, there's a lot more older people unvaccinated. Now, even if you recover from COVID, anywhere between 10 to 30% of patients may have persistent symptoms that they will suffer for anywhere from more than 3 to 6 months. And at this stage, scientists around the world are actively studying this. Will that have impact long-term in terms of the heart, the brain, and so on? If you recover from COVID, your risk of reinfection is generally less than 5%. And we have been also studying this. So you can get reinfected again, but it is not as high as if you are not infected. Okay, so it's very important to understand the effect of age. It is true that in children, COVID is milder, but why did we see a lot of children getting sick and some died in India, in Malaysia now, in Indonesia? So when the epidemic is very big, then even though children gets affected less, the numbers are so big, they will also fall sick. Okay. Now, essentially, when you get old enough, generally above the age of 50, your risk of needing oxygen increases. Okay, and there's a higher increase above 60. Okay, and this is in patients who are not vaccinated. Once vaccinated, your risk is reduced significantly. Okay, and I'll move on next to this effect of vaccination. So I took this from Ministry of Health. Okay, they have been putting it there daily. So when we talk about the sort of severe COVID needing oxygen, end up in ICU or die, in the last 4 weeks, from 26th of August is 1.5%. Versus about close to 14% unvaccinated or partially vaccinated. So 1 dose is not good enough. You need 2 doses. And this has been shown currently in the outbreak in UK, in Israel, in US. The risk of getting very severely sick, needing oxygen ICU, is anywhere between 10 to 20, 30 times more in unvaccinated versus vaccinated. And yet the people that try to persuade you not to take vaccines will not tell you the increased risk, the 14%. They will tell you that 1.5% vaccinated get sick. Okay. Yes, you can get vaccine breakthrough. Okay. So last year, when the trials were reported, whether it's Pfizer, Moderna, AstraZeneca, and this year, whether it's Sinopharm or Sinovac, even if you're vaccinated, you can still get COVID, but you reduce the risk anywhere between 50% to 95%. Okay, so that is that percentage is in terms of infection with symptoms. We always know infections without symptoms is lower. Okay, so before Delta came around, the infection risk of without symptoms is more like 60 to 80%. Okay, the Delta variant, which we first seen in April, changes all that. Okay, the Delta variant reduce this protection even lower. And this is across all vaccines, whether it's Pfizer, Moderna, AstraZeneca, Janssen. We have less data on Sinopharm, Sinovac, but based on whatever is available, the same reduction is also observed. So, but we also know that we have also studied it and submitted to international journals that vaccine breakthrough is a lot milder. You know, I look after COVID patients. I have patients in their 70s and 80s with multiple medical problems. They are vaccinated, and I look at them and I wonder why they are there in hospitals. But at the moment, ministry wants to be very cautious. They get admitted. We monitor them for a certain period before we send them to a recovery center. It is really quite amazing. Of course, you guys have read about the 90-year-old who died who vaccinated. So that belongs to the 1%, but the majority is a lot milder. And we did the blood test, we did the X-rays, totally normal. So the protection by the vaccine remains very high, and all these are the Delta. Okay, vaccine breakthrough is linked to new variants, and currently everywhere over the world, except for South America, is dominated by the Delta variant. Now, in terms of the vaccines, this is what we have currently. We have the mRNA. You know, people keep saying it's new, but you know, the world started in the trial middle of last year. The world first vaccinated with these vaccines in December. So we have close to 9 months of safety data. There are hundreds of millions of people been vaccinated, and UK, Europe, US, and Singapore, we have monitored the safety data. We know a lot about these vaccines, okay? The main side effects of the mRNA vaccines is, number one, a severe allergy. It's not common either. It's between, you know, one in 100,000, okay? And the other thing is that in young people, there's some heart inflammation, okay? Now, heart inflammation outside of this usually is severe, okay? So in COVID, you can get a heart inflammation, you can be very sick. There's a lot of other viruses that cause heart inflammation. The peculiar thing now, in May, when it was just reported, it's much less known, but it's been 3 months now. And Israel and US and also ourselves, we have monitored heart inflammation. The majority of heart inflammation, they recover within a few days. Okay, more than 95% of the patients, young people with heart inflammations, are mild and leave hospital. Of course, there'll be, you know, we heard about a 16-year-old. That is a rare case. In fact, that's probably the only case so far that we are aware of. So these are the two main side effects of the mRNA vaccines. Okay, so a few people have they would like to tell you that people die of terrible diseases after this. I'm aware of Telegram groups of a few thousand people, not just in Singapore, some of them come from overseas, and they share all their bad experiences. So ministry has shared this data, okay? They look at stroke every day, they look at heart attacks every day, and they look at before the vaccines came in, after the vaccine came in, and really there's no increased signal. And this is not just us, it's been examined in the US, in Europe, in UK, in Hong Kong, okay? So why would Ministry of Health lie to you, okay? Because if they lie to you and these are true event, we get busier, okay? We have to look after patients, okay? And the people that tell you this don't show you any evidence other than telling you a story. Now, in active whole virus vaccine, currently there's only 2 from China, Sinovac, Sinopharm. Sinopharm is actually the more, you may have read about the Middle East study with close to 40,000 patients. The Sinovac biggest study is from Brazil, 12,000 patients, still not published. And the effectiveness of Sinovac is actually decent. It's close to AstraZeneca and Janssen. Effectiveness of Sinovac is 50%. And Sinovac itself has published its data to say that after 6 months, the antibody disappears, but it got better with third dose. So Sinovac seems like, you know, is a 3-dose vaccine, but of course at this stage is only officially in China authorized as a 2-dose vaccine. And now after we never have any information from Sinovac, Sinopharm, but now we have some data from Chile. In fact, severe allergy is slightly more than mRNA vaccines, about 1.2 per 100,000. Okay, and the Hong Kong also showed that you get a drop drop in your face much more than the other vaccine. So it's not that there are no side effects. Okay, they do cause less of the fever, the body ache, those mild side effects, but the serious side effects are there. It's just that we didn't have this data until we use it ourselves in Singapore, until Hong Kong published its data a few weeks ago, and Chile released its data a few months ago. The viral vector vaccines, AstraZeneca from UK, Janssen from US, also has a lot of information available. Their main side effect is the blood clots, okay, in young women. And as a result, some countries have reduced its use, but it remains a very effective vaccine. We don't have it in Singapore. So I've told you about known side effects. I've also told you the surveillance safety data, okay? A lot of people like to tell you, oh, some vaccines have no side effects. Well, that's because no one knows, no surveillance is reported to things like Health Science Authority. And it's also untrue that doctors are told not to report. In fact, we are told to report any serious side effects from the vaccines, regardless of whether we think it's related. Okay, because there are so many mild side effects, we don't report, an ache here, a fever there, a headache that lasts a few days. But all serious side effects are reported to Health Science Authority, and it's the same thing in UK, US, and so on. Now, effective against variants of concern. Second half of last year, there's the Alpha variant from UK. At the same time, there is the Beta from South Africa, and there is the Gamma from Brazil. Thankfully, the South African and the Brazilian one have stayed where they are. In fact, they've been replaced by Delta. And earlier this year, sometime in March and April, Delta became the dominant strain, spread from India to Singapore to UK and to everywhere. It has pretty much taken over the whole world except for South America. And with the Delta, all vaccines have reduced effectiveness in preventing infection with symptoms, as well as preventing infection without symptoms. However, what is important to know, whether it's from Israel, UK, and US, as well as Singapore, because we have been having this since April, is that the protection against severe disease remain high. Okay, so then you say, but in UK now, in US now, in Israel now, there are a lot of people who get into hospitals. Isn't that a sign that the vaccines don't protect? But you need to look at the reports from the government in those countries. More than 95% of the severe infections requiring hospitalization and the deaths are in unvaccinated. Okay, is not in the vaccinated. Of course, when there's a large epidemics, when there are 50 to 100,000 cases a day, some vaccinated become sick too, but they tend to be the very old, the very frail, the ones that can't get out of bed with multiple medical problems. Okay, and because in those countries, the old people get vaccinated more, so a lot of the young people now are infected. You have read about reports of younger people. Some of them actually speak against COVID, speak against masks, speak against vaccines. They are now landing in hospitals, and the reports of their death are coming into the media. How about need for boosters? At this stage, we know that most people, young people, people with normal immunity, respond to the vaccines, produce good antibodies. But we also know that in older people, with those with poor immunity, such as cancer patients on treatment, such as transplant patients, their response is much lower. Okay, so in UK, in Israel, they started vaccinating a third dose to these people. Okay, as to whether you need to give everyone a booster, it is still not well decided yet. The reason is this: if you give a boost, you definitely increase the antibody and you reduce your risk for an infection with or without symptoms for a few months. And then the antibody will reduce again. This is the natural response to vaccines. We have things like hepatitis B vaccine, for example. If you measure the antibody after hepatitis B vaccine, it will be very high. And after a while, it will go down. Okay, in some people, it will even disappear. But when you're exposed to hepatitis B again, the vaccine will help to protect you from being infected. There are also myths, okay? WHO, US CDC, UK government, Singapore government, all reputable governments, they only say ivermectin needs to be further studied. We do not recommend its use outside of clinical trials, okay? Now, why would government lie to you? Because if they lie to you, they don't reduce infections, you get sick, they suffer. They can't open their border, and so on. And recently, there's a scandal. One of the study of ivermectin that shows the best effect, it turns out to be fake data and has to be withdrawn, okay? So when you actually study good quality trials, the effect of ivermectin is very, very mild or doesn't exist, okay? And the people that want to tell you not to get vaccinated and take ivermectin, you should actually ask them, if I fall sick, if I end up in hospital, okay, are you going to pay for my bills? And are you going to be responsible for my death? Now, the truth is that a lot of people ask about the vaccine injury insurance. The government has announced it, more than 700,000, more than 120 or 140 patients, tier 1, tier 2, tier 3. The government is, after assessing if it's a valid case, the government is compensating people who've been vaccinated. So far, there's about 100 odd cases, okay? And so the main thing is Delta variant, okay? So we are currently 79%, 85%, 83% one dose. So the key to protect ourselves really is vaccination and mask, okay? I will continue to wear masks pretty much after the pandemic, okay? Because I'm getting old. I have been vaccinated. I'm one of the first. And I know that if I get COVID, I'll be mild, okay? But I worry for the old people out there, okay? Because if you're old, frail, medical problems, it can be severe. And you may have read the report, the 2 recent deaths, they didn't leave the house, but how did they get infected and ended up in death? Someone must have visited them, right? It could be family, it could be relatives, it could be delivery, it could be someone who come and help them, okay? If you are a hermit, you have no contact with humans, you won't catch COVID, okay? So you should get vaccinated. You should tell your family to get vaccinated because it's unpredictable. Of course, if you are prepared, you know, in case you get COVID and you're prepared to for deaths, and I think it's totally fine. If I'm 80, 90 years old, I may not want to go to hospital, that's okay. But most people, in my experience, are not ready for death, okay? When I talk to my parents about death, they're in their 80s, they are not ready either. Oh, what is the problem? So let me tell you what's the problem, okay? There are 13% of those above 70, the highest risk, okay, who have only 1 dose, okay? So if these people get infected, they will be very sick. We need, but look at the rest, 92, 93, 90. So I'm not worried about the others. I'm worried about this group, okay? There are tens of thousands of this group, okay? If they don't get vaccinated, if they get sick, they'll be in big trouble, okay? So please, if you are in this age group, get vaccinated. You don't need an appointment. Your friends or family or neighbors, you know about it, get vaccinated. I have been talking to all my patients as well, and they usually listen to me, and they've been fine. That's all I have. Thank you.
Thank you very much, Professor Lai, for the very informative talk. Next, Dr. Niohani will be sharing with us the more grim aspects in the unfortunate event of contracting and dying with COVID. Dr. Niohani is a senior consultant in geriatrics medicine as well as in palliative medicine. He's the current head of Department of Palliative Medicine at Tan Tock Seng Hospital and serves as an assistant professor for Lee Kong Chian School of Medicine. In addition, Dr. Neo has a keen interest in clinical ethics and now chairs the hospital's Clinical Ethics Committee. Let us now welcome Dr. Neo to speak on the topic, what is so important to know about dying in the era of COVID? Dr. Neo, please.
Thanks, JJ. Hi, everyone. Thanks for spending the afternoon with us for a topic that I think concerns every Singaporean, right? And I'm just going to share screen over here, so just give me a few seconds. Right. Okay. So the reason why I'm giving this talk today is because really amongst doctors in the hospitals, to tell you the truth, in a light-hearted manner. We are really grumbling big time. We were asking ourselves, why is it that the reality that we see from a day-to-day basis, which is so real to us, fails to be convincing, especially to the older folks in the community, And every day we hear of people dying, as JJ, our moderator, have mentioned earlier on. This month alone, there are 18 deaths, and more are expected to come. And the vast majority are amongst the unvaccinated seniors, right? And that got us thinking, what is it that we see, that we know as healthcare professionals, and you don't see and you don't know as a general public, that leads to this discrepancy in belief system. And this is why, we sort of gladly acceded to the request of the organizers, okay, to have this talk. And my job is to let everyone here know the reality that we see in the hospital, so that you can have understanding of not just numbers that we see in the newspapers or the social media, but flesh and blood story of how people contract COVID, get admitted to the hospital, and finally die of COVID. Now, this is the content matter that I'll share today. What is so different about dying with COVID compared to dying from cancer? 1 in 3 Singaporeans die from advanced cancer or its complication. 1 in 5 die from heart attacks. Well, what is so different about dying with COVID-19 that distress doctors, nurses, and healthcare professionals? Are we safe? Like Professor Lai has mentioned, the statistics are looking good. Internationally, we are one of the top players, in terms of getting people vaccinated. With so many people getting vaccinated, aren't we achieving herd immunity? Do we really need to get the rest of the 10% of our seniors to be vaccinated? And of course, I want to delicately touch on this topic about what if we do get infected and we get seriously ill. What is different about dying with COVID-19? Okay, as a palliative care consultant, I see patients who are dying, who has got advanced cancer, advanced organ failure. Many of them don't have many months to go. Many of them will tell me that when their time comes, please help me to die in a comfortable manner. Everyone wants to die like this little baby here, painless, calm, peaceful. They'll tell us, make it quick. If I don't know anything, all the better. I'm worried about the finances. I don't want to burden my family. I don't want my family to be burdened physically, emotionally, or financially if I were to be hit by a critical and terminal illness. So if there were ever a perfect death, it may be just like this little baby, whereby a critical illness strike and we pass away in our sleep suddenly. That is actually a lot of what our Singaporeans will tell us when we pose such a question to them. Now, assuming you take my role today as a palliative care consultant and we start seeing COVID patients in the ICU or in NCID, right? Or in other hospitals. And when they die, what symptoms do they experience? Because COVID-19 predominantly hits our respiratory system, our lungs, our nasal passages. It produces a lot of phlegm, just like pneumonia, okay? It produces problems such as difficulty with breathing, okay, and that's why our patients, especially elderly ones, will get breathless. Now, I'll tell you that in our clinical experience, they will be pretty well in the first few days. It's usually towards the end of the first week when they first develop symptoms that they will suddenly go steeply downhill. So much so that when these patients come in and they have a certain profile, older age group with chronic illnesses, and they start to require a little bit of oxygen, we start tagging them in our system and highlight them as possible cases. Why do we need to do this extra step? It's because they may steeply decline just over a single day. We have seen quite a number go through this trajectory. And you may not have chance to properly speak to them about what they may expect and what treatment they want or do not want. Elderly patients who are unwell because of changes in their biochemistry, their chemicals and hormones in their body, they tend to get confused and restless, particularly in the nighttime. When you have a breathless older person who is confused in the nighttime, who is in an isolation room all by themselves, with no family members around, you can be very certain that the anxiety and the confusion will lead to them being restless. They'll try to remove their mask. When they remove their mask and they move around, they consume more oxygen and they take away oxygen that we try to deliver to them, and they get more breathless. And this just goes in a vicious cycle. And if, let's say, my specialty doesn't come in, or other doctors do not use some of the common medications that we use to reduce breathlessness and phlegm, they die from a death that's equivalent to drowning in air, drowning in phlegm, drowning from a lack of oxygen. That is how patients with pneumonia die, if they get severely breathless without help. Now, Dr. Lai has mentioned earlier on, so if, let's say, a person turns ill and he needs oxygen, we start off by giving patients oxygen at the nose tip, what we call the nasal cannula. If that doesn't work, we move on to the face mask that you see on TV and drama series. Now, if the patient is relatively fit, we may still need to escalate it further to what we call high flow nasal cannula. And finally, if a person is fit and suitable to go to ICU and continue to deteriorate such that the patient needs machine to sustain life, we will have to bring this patient to the ICU. And that's where you see this picture here, whereby we insert a breathing tube into the mouth and into the throat so that the machine can be connected to this tube to help you breathe. And in some of our COVID-19 patients who have a very long and protracted stay in the ICU, we can't keep this tube for too long because it may cause problems with the throat, and it may introduce infection. That's when we do a minor surgery to open up an opening in the throat and insert another tube in to link it up to the machine. So what you may get really is that if you turn severely ill, you may need to go to the ICU and be ventilated with a machine, right? Now, we do know that 26% of unvaccinated patients needed oxygen compared to 2.8% of vaccinated patients. Now, the risk is similar to what Dr. Lai has mentioned earlier on. And in the ICU, besides the breathing tube, right, because you have something in your mouth, you can't eat on your own, we have to insert a feeding tube through your nose to feed in the nutrition, the milk product, right, the artificial milk product. We need to insert a urine tube into your private part to drain your urine to know how much fluid we put into you and how much urine is drained out. That also is invasive and uncomfortable. You have to put a tube inside your wrist to measure the blood pressure continuously. You have to put another tube in your neck in order to monitor other parameters related to your heart and lung function. And some cases of COVID-19, they go beyond just a single organ failure, beyond just a lung failure, to include multi-organ failure, often involving the kidney. And that's when they need dialysis. And there will be another tube inserted into your groin, or into your chest to initiate dialysis. Now, we have talked about ICU. What about those patients who do not want ICU, or who are not suitable to go to ICU? What is different about COVID-19? Now, before the pandemic, as palliative care physicians, our life is so much easier. We call in our social workers, we call in our nurses, we bring our families together. We try to support a dying patient through the last journey so that the patient can be comfortable, the family can be reassured. But now with this pandemic, especially if you treat a COVID patient, I'm sorry, you die alone. We have seen so many heartbreaking stories. It really gives us nightmares. So this is a picture of NCID. This is the isolation room. And just outside this isolation room, you see a small space whereby if you're inside, and your family member happens not to be quarantined, they can come to at most this point, just outside the door, to just look at you. They can't go in. And they probably only see you like this if you're not doing so well. And I mentioned, if you're an older person, and you are in a single room on your own in the nighttime, you can't sleep, you're confused, you start having hallucination, you're breathless, you're unwell, you can't call it a good death. Your family members, the majority of your closest family members that perhaps live with you, will not be able to come and visit you because they will be quarantined. They may have transmitted the virus to you. They themselves are quarantined and feeling very guilty that somehow they may have transmitted the virus to you, particularly, if you have taken all the precautions you have to hide at home. And the most that we can do, and this is what internationally, including Singapore, we are doing, we're getting our nurses and doctors to use a phone device or an iPad to help video call our patients' family members. And it is very heartbreaking to see how they say their final goodbye, right? Is this the way that you want to die? Is this a common person, how a common person would die from perhaps a heart attack, a cancer, or stroke? No, this death is a lonely journey. You will not be able to see them. You will not be able to feel them. You will have symptoms that you need a palliative care specialist to give medicine to reduce. Okay, I can't really call this a good death at all. Now, for those of you out there, especially the older generation who are rather thinking every other year, birthday pass, when is it my time? I'm sorry, this is still supposedly the 7th lunar month, but please don't be a taboo. Please don't take it as a taboo. How do COVID patients die, and what's the funeral arrangement like? Okay. Now, I'm sorry, the body will have to be treated as a biological risk. Now, how much human dignity is left in that? Okay, by biological risk, it means that there's a chance that, the secretions and the virus in your respiratory tract can be transmitted to other people who handles your body, be it the undertaker, the mortuary director, the doctors and nurses, and such like. So the body will be double wrapped in plastic. If the body is returned to the patient's family, provided that the family is not quarantined, okay, and is able to take the body back for proper funeral arrangement. Now, I say that because there are times whereby all family members are quarantined and there's no one to collect the body, and it lies in a mortuary waiting for someone to collect them, right? After all that, the body with the hospital clothes, okay, given that many family members are quarantined, no one can bring them a proper set of clothes that they like, goes into a closed coffin. There's no panel, glass panel for you to see, or for the coffin to be open for you to say your final goodbye. MOH dictates that this will be a 3-day funeral. And most of the time, not many people will want to come out of fear, rational or irrational, or due to social restrictions because of the ongoing pandemic. Again, this is where family members are extremely sad and extremely emotional, right? They tell us, in fact, I just had a meeting yesterday with the head of department on infectious disease and Tan Tok Sing and the social workers and nurses there. And the social workers say how sad they are that they can't even change them into proper clothes. They can't even see what they look like when the patient passed away. And the body just goes into the coffin the next time they see their loved one. This is how different dying from COVID means compared to dying from cancer. Right? So a lot of our older seniors may say, I'm 80 years old, I'm 70 years old, I'm prepared to go, whatever it is, I'm prepared to go. But do they understand that when they go, this is what it entails? This is the sob story, and this is the heart-wrenching story that we see as doctors and nurses at NCID and in the ICU, right? And when they bang table and they shout at us, they threaten to complain, we don't blame them because we know that they need to find an outlet to ventilate their guilt, their grief, their anger, and their frustration. But can this be prevented? Can this be prevented? Like what Dr. Lai said, it can very well have been prevented. The people who stay behind doesn't take it easy, right? Now, this is what we call complicated grief. And besides, when our loved ones pass away, all of us will grieve, but it becomes a pathologic condition, a psychiatric disorder, where we keep grieving and we can't get out of it and we cannot return to our normal life. And our family members may suffer from complicated grief because, the older person, or perhaps a younger person who contracted COVID and died, often die a sudden and unexpected death. Okay? People who live with them may be quarantined. They may be the one that may have transmitted the virus to the older, frail adult. The circumstances surrounding their death is unusual, isolated, lonesome, no one can visit, no one can hold their hands, no proper funeral. And if you are seeking social support amongst your siblings, very difficult because you may be quarantined at home. And so the people who are left behind will have a lot of grief and bereavement and guilt to deal with. And sometimes they'll ask the doctors, can you do everything possible, which we have seen, to sustain life so that at least we can come and visit? And the doctors will have to touch our heart and think very deeply whether we should do that, because sometimes we know our patients can't make it. And if we want to sustain their life, it means subjecting them to many invasive and uncomfortable procedures in the ICU, knowing that they will only die a few days or a few weeks later. And we sometimes have to ask our family members the very difficult questions. Are you asking us to sustain them, although we both know that she'll eventually die? Is it because of your guilt, or is it because of the patient themselves? They are not having a good time in the ICU. Now, we are all hoping for herd immunity. We have heard that for our citizens 60 years and above, 89% have received both inoculations, both vaccinations. Are we safe? Are you safe? Okay. Now, as Dr. Lai has mentioned, the Delta variant is more contagious than the previous variant. The previous variant can spread, one person can spread to, I can't remember, 3 or 4 people. Yeah, Dr. Lai can correct me if my numbers are wrong. But we are suspecting the Delta variant can be so contagious, one person can spread to 8 to 9 people. It can cause perhaps more severe illness than previous strains in unvaccinated folks. And we do know that unvaccinated folks are more likely to contract and transmit the virus. Now that we are vaccinated, it doesn't mean that it's 100% effective. Okay, we do know that even if you have the vaccine, you can still catch the virus. But the people who are vaccinated are very much more likely to not have any symptoms at all, or if they do, just very mild symptoms. And the data is very convincing that the vaccine protects us strongly against serious illness, ICU admissions, and death. Now, you may also want to know that the Delta variant seems to be producing a higher amount of virus both in the vaccinated and unvaccinated people. And people will start to ask questions and say, hey, why should I get vaccinated then, since if I'm contracted the Delta variant, I have the same amount of virus as an unvaccinated people. But we do also know from some local data that after you are vaccinated, your virus load in your body starts to reduce, much faster than if you are not vaccinated, which means vaccinated people, potentially, even if they get contracted, carries the virus in a transmissible load over a shorter period of time than unvaccinated people. Now, you ask yourself, can I hide my older parent at home so that they don't go out of the house, they'll be okay, rather than risk them having, major problems with vaccination? This was what we had hoped before, herd immunity, whereby we have people all vaccinated, producing sort of a circle of protection for a vulnerable group that's unvaccinated. Right? Now, I don't think herd immunity, personally, I don't think herd immunity would be the way to go, because the predominant strain now is the Delta variant, which is more contagious. I mentioned earlier on, both infected and vaccinated carers can have no symptoms. And we do know for sure, rationally, that as social restrictions are lifted, as we prepare for endemicity, community transmission will rise. It is already happening around us. You just look at the numbers, you know. Right? So is it going to work? Is it going to be a main strategy to help us get out of this pandemic? Herd immunity by itself, I'm not so sure. Right? Now, I can't share personal, confidential information about patients that we care for. But this is a patient whose family member came out to the open and shared their story in the public domain, in the newspaper. I think it was the newspaper. Yeah. And this is a very elderly patient who spends most of her time at home, who has hypertension, who has diabetes, not uncommon in patients with her age group, or in her age group, right? And she started coughing in July. That's the market cluster. She was well. She didn't have any issues. Okay, and her carers were all fully vaccinated. So this is the account given by the daughter-in-law. My family did not feel too afraid of COVID-19 because we didn't think it was so real and so pertinent to us. Like I said, the alternative reality that I see is different from what you see, right? To the public, COVID-19 is not a very real thing. It's still very distant, When cases are reported, it's just numbers, right? But after her mother-in-law's passing, she realized how real COVID-19 it is, and they really regret not seeing the urgency to get her vaccinated. And she was rather unfortunate because she was due for vaccination, but she was a little bit unwell and she postponed it. Now, I'm not kidding you here, okay? This is in Straits Times, okay? And this is Professor Alex Cook, okay? Associate Professor of Public Health. I think he's working with NUS, right? And using mathematical modeling, we're looking at 1,000 deaths in the next year if the vaccination reaches 80% in this age group of seniors. If we hit 95%, maybe we can be lucky and get away with a few hundred deaths a year. Mind you, again, I emphasize, it's a few hundred deaths a year. Okay, am I quoting from just one single study? No. In fact, Straits Times has been sending very clear information out, signals or otherwise, depends on whether you want to pick it up, okay? And this is published in 13th of August, okay, by another professor, okay, who tells you that this mathematical model that's done again in School of Public Health, okay, shows that we are looking at hundreds and thousands of ICU admissions and hundreds of deaths. And this is not a theoretical possibility, but this is something that's repeated worldwide, okay, worldwide. Now, if you just look at the bar below, which is the number of deaths in August alone, okay, you can see one death almost every other day and one death continuously every day the past 1 week. And do remember that these patients who died probably contracted the illness during the period whereby social restrictions were still stricter than now. So if you look at one death per day or more, the prediction won't be too far off of a few hundred deaths a year. Okay, and most of these deaths, as Dr. Lai has also mentioned, is mainly among seniors above the age of 60 with some chronic illnesses. Chronic illnesses may not mean advanced cancer or advanced organ failure, mind you. And we see younger patients as well, who were previously relatively well. Okay, I hate to be, cliched. There's a government website that you can take a picture of. For older adults who really can't get out of their homes because they are very frail, they can't walk around to the polyclinic or the vaccination center so easily. This is the hotline to call for home vaccinations. They've got home vaccination teams that go to the patient's house to do a vaccination for the patient. Now, what if I get infected? This is the picture of a person in the ICU, a rather typical picture. A tube in the throat or a tube in the neck, a tube in a private area, tubes in the neck, tubes in the wrist, tubes everywhere, basically. Okay. Now, if someone turns severely sick, needing high quantity of oxygen, do we send all our patients to ICU? No. Okay, no. The doctors will have to weigh between the survival probability if we send a person to ICU versus the discomfort related to treatment, the anticipated quality of life if the patient survives, okay, and the amount of function that may be left after ICU stay, whether he's still able to self-care. Generally, the older you are, especially the 80 and 90 years old, even before the pandemic, not related to COVID-19, the likelihood of going out ICU alive is already not great. 1 in 3, and this 1 in 3 that survives the ICU continue to have a high rate of dying, in the hospital, and the next 1 year if they survive the hospital stay. And some of them who have deteriorated in terms of their ability to self-care. So what if I contracted COVID? And what if I am unvaccinated and I'm one of those with chronic illnesses? Okay, who would the doctor send to ICU? Okay, the doctor will look at patient profile. Age will be an important consideration factor. The very old don't do so well. We look at the person's reserves, his ability to self-care, what he has mentioned before to his family about what he wants, what is important to him. We'll look at the illness in the person's body, how many organs were involved, how many organs were already not good to begin with, how severe is the illnesses. And then we have to base on evidence and experience, what's the likelihood of treatment response, what's the probability of survival, and what is the discomfort related to treatment. And here comes an important point. Like I mentioned before, people tend to deteriorate very quickly towards the end of the first week, sometimes within a single day, from not requiring oxygen or requiring just a little bit of oxygen, and they drop and they need to be sent to the ICU quickly. Okay. So that is why if you have contracted COVID and you are not vaccinated and you have chronic illnesses and if you are elderly, it's important then that you tell your family members what is important to you. Do you feel that further life prolongation would be important at the expense of your quality of life? Because, like I mentioned, there will be a lot of procedures done in the ICU. Many of them may not be comfortable. Okay, and who would you want to assign to be a representative to sort of air your views to the doctor should you lose the ability to talk? So I copied this slide from one of my previous presentations. Okay, so if let's say the doctor tells you that you have a good chance to survive, there's a short-term suffering, your long-term quality of life will be good, we should go to ICU. There's no reason why we shouldn't. But if the doctor tells you or your family member, depending on whether you're the patient or the carer, that look at it, it's not good, even if we send to the ICU, it will just be a very protracted suffering and the patient will still die, then no, shouldn't, right? But if you were to go to the ICU and so you might survive, but your quality of life will be very poor. You may be bedbound, you may not be able to talk, you may be dependent on a machine. then that's very much dependent on your values and what you view to be important, which is why you must speak to your family and your doctors if you're admitted early, if you're contracted the COVID virus, about what level of treatment you feel will be important. But mind you, the important thing is this, right? Many people think that if I want to go to ICU, I'll naturally be admitted to ICU. No, the decision whether you go to ICU or not is contingent on the doctor's assessment of the situation. You can express your views, and we definitely will want to hear it, and we'll try to respect it. But if the chances are too poor and the complications are too high and the suffering is too much, you may say no. So to conclude, okay, now the Delta virus, the Delta variant is not the usual variant that we knew from 1.5 years ago, okay? When people die from COVID, not only they suffer from a lonesome death, there is a lot of guilt and a lot of psychological trauma to those who leave behind. The virus itself, like I mentioned, will continue, even amongst our midst. Transmission will definitely rise in the community, and even the vaccinated may become infected, although the vaccinated are much less likely to be symptomatic or to have severe illness or to die, right? And if I were to be admitted to ICU, or if my family members were to be admitted to NCID and turn very sick, now before they turn sick, it's important to first have that conversation about what is important. Okay, and that will be the end, almost the end of my slide. A bit of hard selling here. You see, PN, he's also considered a senior. He's one of the first to be vaccinated. Okay, there are other vaccinated folks. Okay, I borrowed these pictures from Straits Times. Okay, they are vaccinated, and this is I think was it a 90 or 102 years old, one of our longest eldest survivors of COVID. She's one of the very lucky few that managed to see her son over many, many months. Now, I'll end off with telling you this. All of us will develop antibody to the coronavirus. It's whether you develop antibodies because of vaccination or you develop the antibodies because of infection. Now, we are lucky in Singapore because we are given a choice. We have access to these vaccines. Countries in other places may not have access to the same vaccines, with the same efficacy, the same evidence that we have in Singapore. And you have a choice to tell your family members whether they should be vaccinated, right? And I think you need to exercise that choice urgently and wisely, because we're expecting a rise in numbers over the next few months. Okay, with that, I end my talk. Thank you.
Thank you very much, Dr. Neo, for the very informative talk. We hope that after these two talks, we now have much better information about vaccination as well as living and dying with COVID. Now, if you have any further doubts, this is now the time to clarify with our two medical experts. We have received many questions submitted before today, and you're welcome to continue to submit further questions through the chat box. Already, we see many questions have been coming in very quickly, and Professor Lai has been answering some of them already. But we will continue to ask the rest of them. But in the interest of time, we may have to collate and combine some of the questions. We will also try to focus on questions which are directly related to today's topics. So we ask for your forgiveness in advance if you are not able to field all your questions. So let us now start with the first question. The first question is it true that COVID-19 vaccine will trigger a worsening of underlying chronic illnesses such as kidney failure, anemia, hypertension, heart attacks, and strokes?
Now, we have had close to 9 months of data in hundreds of millions of people vaccinated now, whether it is AstraZeneca, and Pfizer, Moderna, and from the Chile data on Sinovac, 6 million people. We don't see this, but unfortunately, whether it's on social media, whether it's here, whether it's on Telegram, there'll be people who are often anonymous, who don't tell you who they are. They will tell you that. Okay. Now, every day, now some of it is observation. Every day, someone's going to have a heart attack, someone's going to have a stroke, okay? In my lifetime, I have not seen the whole world vaccinating more than 5 billion people now, okay? So you are going to see this coincidence, okay? The way we decide whether it's real or not is to look at the rates of heart attack and stroke for many months before we start vaccinating and after vaccination, okay? On an individual case, it is impossible to tell, okay? In the past, we have definitely seen signals like this, okay? And for example, that is how we detected a slight increased risk in severe allergy. That's how we detect the mild heart inflammation in children, okay? So it shows that the system works. So if you ask me, is it true? My answer is not true that the COVID vaccination, whether it's Pfizer, Moderna, Sinopharm, trigger any of these things. However, if you have this condition and you don't get vaccinated, you get COVID, you'll definitely be at much higher risk of getting very sick and seeing me in NCID.
Thank you very much, Professor Lai. There's another question. I have allergies to many types of food, alcoholic beverage, and medicine. Can I take the vaccine? If so, which one is safer?
So the only allergy you have to worry about is allergy to the vaccine itself, okay? I know we are a bit kiasu initially, so it confuses people, but the rest of the world hasn't been kiasu, okay? So, you know, millions of people, hundreds of millions of people have been vaccinated with food allergy, with antibiotic allergy, and there's not been a problem, okay? Allergy to insect bite, allergy to food, allergy to prawns, allergy to Panadol, antibiotics do not increase your risk of allergy to vaccines. But if you do have an allergy after the first dose of any vaccine, you see your doctor and you may be considered for an alternative vaccine.
Okay, thank you. Another question. What does cancer patients and people with some serious illnesses have to watch out for?
If they catch COVID, the risk of severe disease is very, very high. From overseas report, it is anywhere in 30 to 40%, much higher than someone without cancer. And vaccination protects them, but we also know in these patients that their response to vaccination is lower. So a study has come out, a proper trial has shown that a third dose in transplant patient, that's not cancer, that's transplant, but they're similar, actually increase the response better. Okay, so this is definitely a group that will benefit from a third dose, but the vaccination itself doesn't cause more side effects in these people.
Can I just add in here, not so much about the research statistics, but what we are doing on the ground. About half a year ago, within the hospital, we'll be saying that patients with less than 6 months of expected life expectancy from advanced illnesses, we may not recommend vaccination. But because we're expecting transmission rates to rise in the community, we are now shifting towards trying to even look at patients with advanced illness, cancers, advanced organ failure, whereby their life expectancy may be in very short months, as short as 3 or 1 month, and we are still saying maybe it's good to encourage them to be vaccinated because of the kind of quality of death, as well as what they have to go through before they die. So practically, we're actually doing that on the ground already. Thanks.
Thank you very much. There's a question in the box, in the chat box. Professor Lai, my 85-year-old mother is currently unvaccinated. She's waiting to take Sinopharm. Can you please repeat again the efficacy of Sinopharm against the Delta variant in particular?
Yeah. So the answer to this question is that I can't, because the countries that use Sinopharm have not reported the data, okay? But Sinopharm produces antibody and what we call the T cells, fairly similar to AstraZeneca. So, if you ask me to advise you, I would say it's likely to work roughly at the same level as AstraZeneca. But the truth is that, like, we can tell you how much Pfizer Moderna works for Delta because we use it here. We've analyzed, and ministers have shared that it's about 50 to 60% effective in protecting it. It's more than 95 to 99% effective in preventing severe illness. Okay, but I can't tell you about Sinopharm. I may be able to tell you in a few months' time because Sinopharm has just arrived. Okay, but at this stage I can't because the country that use it has not produced that data.
The next question. Patients who are severely frail, can vaccinating them shorten their lifespan? For example, my parent had a stroke and is bedridden and uncommunicative. Should she be vaccinated?
Now, this is a rather difficult question. Okay, I will have to answer it very realistically as a geriatrician, right? People who are in these states, their overall life expectancy can be predicted to be rather low. How low, we can't tell, right? It is really a subjective, value-based decision about what's your gamble here. Are you going to gamble that you will not catch COVID over the longer term? Okay, or will she perhaps, I'm so sorry to say this, but pass away from another illness before she catches COVID, right? The truth is that we do know that no matter where you are now, how you hide our loved ones, there's a high chance that over time, we will transmit the virus to them regardless, right? So this is going to be down to your personal gamble. And from what we know now, based on the side effects and all that, even patients who are 90 years old, 80 years old have taken a vaccine with minimal problems, except for some headaches and fevers. So I think that's something they have to consider strongly. How's the likelihood of her catching COVID over the longer term based on what we tell you? Okay. And the likelihood of her passing away naturally from other illnesses. Right? I think that's as best I can say it. Yeah. Dr. Lai, you have anything to add about this?
So my view is this, right? So if you are prepared, for death, okay? If you are prepared for death, okay, then answer is yes. But many children, when faced with a sick parent, are not prepared for death. I had the same question with my own parents in their 80s. Okay, they are both very frail. They've been falling over. They are not prepared for death. Okay, so they both took Pfizer on my advice. So, but if you get infected, you'll be separated from your family. Okay, so my colleague Dr. Neo has emphasized that. Okay, and old people doesn't want to die alone in hospitals. I mean, I've heard that many times in my years as a doctor.
Thank you. There are a few questions all related to boosters. Basically, how long can the vaccine last? Do we need boosters after 2 doses of Pfizer? And if so, which vaccine is better? Is it better to continue with the same vaccine, or maybe a different type of vaccine, a mixture of the different type of vaccine? And would it be better then to go for AstraZeneca or Sinovac or Sinopharm?
JJ, can you repeat the question again?
Sorry. The question is about the need for booster.
Okay.
How long can the vaccine last? And also, if there's a need for booster, is it better to go for the same type or maybe a mixture of a different type of vaccine?
Yeah. So it's a very good question. And I'll explain why certain governments recommend things differently from WHO. Okay. Governments want to protect their own people. Okay. What we know currently, as I mentioned earlier in my talk, the increase in hospitalization as well as death in UK, in UN, and Israel are due to Delta. Okay. But more than 95% of them are in the unvaccinated, which means about 5% is unvaccinated. Okay. And there is there's some evidence currently that with time, the antibody will go down. So although it is still 95% effective in preventing severe illness, if there's a lot of people who are sick, even the vaccinated numbers will be quite high. And that will also end up with a lot of people going to hospitals, and the beds become a problem, which is what we saw in India, what we are currently seeing in Malaysia, what we are currently seeing in Indonesia. Okay. And therefore, by providing a booster, they hope to reduce that further. Okay. But if you read carefully the government reports in all these countries, more than 95% of the current hospitalization and deaths are unvaccinated. Okay. Now, people have asked, if there is death in vaccinated, doesn't mean it's not effective. No, because vaccination reduces your chance by 10 to 30-fold. Okay. It's just that, and I already told you who are the ones that die despite vaccination. You have our local experience, 90-year-old, okay? But there are also other 80, 90-year-old who didn't die, okay? But, we can't prevent every single death, but we can reduce it substantially.
Thank you very much. There is an inquiry here. So I have a high BP, diabetes, irregular heartbeat, and so not confident to take the jab. What is the alternative for me?
Well, with all diabetes and hypertension are the two main medical conditions other than cancer and renal failure, dialysis, which increase your risk of severe COVID. Most of my patients with this condition have been vaccinated. Some people feel that their blood pressure goes up after vaccination. You can reduce that by not rushing for your vaccination, by making sure you take your medication in the morning that you go for your vaccination. But by and large, you are at a much higher risk of getting bad COVID, and vaccination can reduce your risk substantially.
Thank you. Should we be worried about potential long-term side effects associated with the vaccines? There are reputable scientists and doctors in the world that are concerned with this, including potential autoimmune disease, ADE, cancer, infertility, etc.
Some concerns are valid and others are not. Okay, so as I said, you can wait for 1 year, 2 years, 3 years, while the rest of us get vaccinated. But you basically put yourself at risk of getting COVID and suffering from it. Okay, and it is your personal decision. But if you go around telling people not to get vaccinated, then you must be prepared to be responsible for them when you get in hospitals, paying the bills of ICU stay, and subsequently dying. And I think personal belief and decision is fine. I don't agree with that stand. I do not know what will happen to me in a year or two. I may have a car accident, I may be struck by lightning, but I know that vaccination will protect me against this virus. We are conducting studies to monitor this in collaboration with scientists in the world. We know currently increasing data in pregnancy is safe. Of course, there'll be people who tell you that mRNA alters your DNA, but they can't show you the evidence. Okay, they will say it. They will quote people who no longer do active research, but they can't show you the evidence that is unsafe. And in the meantime, we have pregnant women who get infected, who are very sick. Okay, so it is something that is, I personally feel very angry about that, because the people that persuades people not to take the vaccine, they don't go there, they don't tell you who they are. Okay, we are the one that look after patients. Honey is the one that look after them before they die.
Can I just follow up on this point again on mRNA affecting the DNA? Dr. Lai, just weigh in if I'm wrong here. But the vaccine itself, the mRNA does not even enter the nucleus of the cell where your DNA is kept. It enters the cytoplasm, which is just outside the nucleus. And within 1 or 2 days, the cell itself will metabolize the mRNA vaccine away. So it doesn't stay long-term inside your cell anyway. So I think when people make such false claims, it's important to verify these facts. I know there's a lot of information out there. It may sound very convincing, but it's important to hear from the proper channel, because if not, then we endanger not only ourselves, but who we speak to and discuss these issues. So get the facts correct. That is actually a responsibility for all citizens.
Thank you. There's a question to say that I have drug allergies, and I'm not so sure about whether that drug allergy would mean that I'm not eligible for the vaccines. So how do I know that my drug allergy will not prevent me from taking this mRNA vaccine?
Well, because we've been vaccinating a lot of people with drug allergy already, we're vaccinated, nearly 80% of people, 10% have some drug allergy, and they've been fine. I mean, some will get allergy, but they're not usually severe.
there's a related question. After the first dose of Pfizer, I had allergic reaction and was advised not to continue. So may I know what is the effectiveness of having just one dose of vaccine?
So if your doctor has assessed your allergy to be real and advised you not to have a second dose, I would advise you to go for, at the moment, there are several options. MOH has sent out the invitations to people to receive Sinovac at the 3 hospitals, Tan Tock Seng, SGH, and UH. Sinovac may be still available from the private clinics, although I was told that they have run out. Sinopharm just arrived. So we are still hoping that the other vaccines that we ordered, Novavax, will arrive very soon, but there's a worldwide production issue. So you should get a second dose. You should get a second dose of another vaccine, because one dose of a vaccine will not be enough with Delta. Can I answer this question on booster, because I'm afraid I got carried away because it is so at the moment, who needs booster? I think people who are very frail with cancer, with transplant, who we know the antibody is not as good. Those people getting a third booster is reasonable. At the moment, UK suggests that, Israel suggests that, US suggests that. Okay, Ministry of Health, obviously, as Minister said, is still thinking. Just wait for the advice. But generally, we started a bit later. UK, US, Israel started in December. We started in January, February. So these are the people who may benefit from a third dose.
Professor Lai, you mentioned about the antibody level. So therefore, is it advisable for such patients, or in fact for any one of us, to maybe do an antibody test to see whether we should therefore take a booster dose?
It is really quite difficult to do blood tests on 5.7 million people, right? And so if you look at what is being done, is people study a group of people, they then observe that that the antibody level is lower in patients with cancer, with transplant, old people. Then governments make decisions to give them a third dose. So and even if you do your antibody test, so for example, the one from the private clinics is called the S antibody. What does it mean when you have a 10, 20, 50, 100? At this stage, it's not very clear. So I think personally, if I were a member of the public, I would just say, if the government offers me to take, I will just follow the advice of the government. I don't think going for antibody test will help you, because I don't know what a number of 50 versus a number of 250 means currently, and how do you test antibody in 5.7 million people?
Thank you. There's a question now about children. Are there evidence that children below 12 can be vaccinated soon? And if so, is it safe, and which type of vaccine will be suitable?
So the answer is that the clinical trials are ongoing. The only clinical trial in children below 12 that's supposed to be completed is Sinovac. But once again, there's no data other than the company saying that it's effective. Pfizer, Moderna, AstraZeneca are currently conducting their clinical trials in those below 12. We understand that the data should be available end of this year. The vaccine will be available early next year. Okay, so it may not be the same dose of vaccine. So let me answer this question of children, because a few people have asked that in the chat box. So definitely, children by and large have a lower risk than adults, unless they have medical problems, and we do know there are sick children. Okay, but what happens in India, in Malaysia, Indonesia currently, we observe with sadness our neighbors, is when a large epidemic sweeps through society, it infects everyone. And even if you've got a 1 or 2% risk of severe disease, when there are a lot of them, there are hundreds of them ending up in hospitals and some dying. And children, I mean, when you get old enough, you will die. Okay, so all death is not good news, but it's different when you die when you are 15 versus when you die when you're 90. Okay, so we basically tell everyone to get vaccinated, and we are grateful that more than 90% of those above 12 have been vaccinated. Okay, and so far we have been monitoring. As you know, HSA has already released the safety data. Other than that, 16-year-old, there's been no great issue, and so under 12, wait for the data, because we won't. There are parents who ask. I got colleagues with children below 12, and they are worried when the cases increase, because nowadays cases seems to be increasing. But wait for the data.
Thank you very much, Professor Lai. There's a specifically question on are there studies done on children with autism, and what is the impact of the vaccine on that?
I'm not aware that children with autism are particularly included or excluded from the trial. That vaccine causes autism is one of the great scandals in medicine by Dr. Andrew Wakefield in the late 90s. And all the anti-vaccine people use it as an example. It's since shown to be untrue, and basically Dr. Andrew Wakefield has been deregistered in UK. So if a child has autism, it would be slightly at increased risk of bad COVID. I think vaccination is a good idea if you're above 12 at this stage.
Okay, thank you. Will the asymptomatics inevitably experience long COVID symptoms like the symptomatics?
So we have studied long COVID, and we've also studied, I'll share this with you, okay? So we studied long COVID in Singapore, and we realized that it's related to the severity of your COVID, okay? So those with severe COVID are much more likely than people with mild COVID and no symptoms from suffering symptoms up to 6 months later. Not just in terms of their symptoms, we also measure their immune system, and it's very different, okay? So if you ask me, are people with mild COVID or no symptoms like they have long COVID? My answer is, based on what we know, answer is much, much less. Now, what about the vaccine breakthrough? So we produced one of the work that's cited by WHO and US CDC as well in vaccine breakthrough in Delta. We also show that the immune system in the vaccine breakthrough is almost like patients who have not been infected, okay? Vaccinated, not infected. And so, therefore, the chance of you having long COVID, I suspect, will be very, very low as well, compared with those who are unvaccinated with severe COVID. Because we can measure the markers in the immune system that are associated with long COVID, okay? So I hope that clarifies this idea of long COVID. Over.
Thank you. There's a comment here to say that we have on average 800 flu deaths annually in Singapore. So if 50 COVID deaths in 1.5 years means a pandemic, then what would 800 deaths per year mean?
So the problem with these people is, it could be a valid question. So let me tell you something, okay? The flu deaths quoted occurs before the pandemic, okay? Where we don't shut down the borders, we don't wear masks when we go out, okay? Since we have done this, the number of flus have decreased significantly. In fact, most of last year, there was no flu, okay? There's no flu death. The reason of our low number of deaths, I'll tell you why, okay? Healthcare workers have been working continuously. All the patients with COVID are tested. We send to the hospital for monitoring, okay? And we treat you early. And all the best treatment in the world, there are 5 proven treatments currently in the world, okay? Remdesivir, steroid, 2 rheumatoid arthritis drug, paroxetine, tocilizumab, and the monoclonal antibodies are all available in Singapore. Okay, they are expensive, and the government subsidizes it. Okay, and that's why and the intensive care in Singapore is great. Okay, Dr. Neo Han Yi is a palliative care physician. He comes to NCID to help look after patients. Okay, we have not been allowed to travel. Singaporeans can still travel with SSN, but healthcare worker cannot travel at all. Okay, until recently we allowed 1 day of leave a week. We can't even go on cruise to nowhere except with approval. So the reason why deaths are low is because of the healthcare system. Okay, not because of someone saying that ivermectin works, hydroxychloroquine works, and flu deaths and COVID death is not real.
May I just add on here that it doesn't mean that flu by itself is something that we don't deal with. We ask our older patients to have a flu jab at least once a year. That there are side effects to the flu vaccines as well. There are minor, low frequency, major problems that can come to the flu vaccine. But do you not take your flu vaccine at the polyclinic? You still do, because the flu vaccine protects you from severe pneumonia and from deaths. And we also do know that COVID-19 is definitely much more fatal. It causes more severe illnesses than the flu virus itself. Right? So the fact that flu is controlled is because everyone is wearing masks in the community. Everyone is very health conscious nowadays as well. Right? But does it then mean that because flu is controlled, we don't tackle COVID? No. After COVID, we should still be health conscious because we want to prevent every possible death that is preventable, because of hygiene practices and so on, because there is science to prove that we can help to prevent severe illnesses. Right. I think governments can look at big numbers to see whether or not it is okay to open up the economy for the general good of the whole public. But as citizens ourselves, as individuals, we have to weigh the risk and benefit for us as an individual and as our families. I think that's our job. It's separate from the government. They take a slightly different view from a different perspective. For us, it's really a weighing of the evidence, whether it will protect us, it will protect our family in the short run, okay, and look at general situation and assess the risk. Yeah, that's all I have to say. Thanks.
Thank you. The next question is regarding probably for Dr. Neo. Why can't we go into the isolation room to keep our loved one company as they die? We are prepared to be infected. We are prepared to be isolated. Why can't the hospital just provide us with the PPE when we come?
So what's going to happen when you leave the hospital? We can't have our family members stay overnight in the same cubicle or the same isolation room as our patient non-stop and continuously, can we? Right? We can't do that. And what if you were to leave the hospital, along the way you meet a member of the public who is having cancer treatment because chemotherapy that affects the immune system, and you just happen to remove your mask and you had a drink of water. So there are all these implications on public health that the hospital have to mitigate. The hospital is not like a general community. We have vulnerable patients in the wards who are sick, who are old, who have immune system problems, who are on chemotherapy, who have cancer, for example, and we cannot risk having a spread of an infection as a cluster within the ward, because once you do that, the impact is multiplied manifold. It means that the whole ward will have to shut down. Patients have to be isolated. Even if they don't contract COVID, then members cannot see them. Okay, not to mention there's also concurrent risk of spreading to other healthcare workers who will then spread to other patients in the ward. In such a setting, it is very painful to see patients and family members being separated despite them being critically ill. It is not something that any doctor would wish upon themselves or their family members or anyone, but it is really for the sake of public good that we're trying to prevent the same tragedy from happening multifold to many other members of the public. So I hope everyone can understand that it is not the desire of any hospital or any doctors to enforce such seemingly non-humanistic regulations on a person who is grieving, okay, but it's something that's necessary to reduce further tragedies. Yeah, thanks.
Thank you, Dr. Neo. There's a related question. It said, if our family member is down with COVID and isolated in the hospital, what can we do to help them?
I think this is something that's going to be very challenging. Okay, you have to tell the nurses that can you please help me get in a phone so that I can have some form of video communication with them. Okay, you can also send in things if you are not quarantined. You can get it in. If you are quarantined, you can send another family member to send in things to the ward. Okay, for example, if a person desires certain religious items, if they are sick, some chanting, a prayer bead, rosary beads, religious effigy, you can actually ask someone who is not quarantined to send these items, and the nurses can bring into the room. But be mindful that the items will not be able to leave that room subsequently for infection control purposes. Now, if the loved one is truly dying, okay, and it's not for ICU, and he may or may not hear us, then there are these 4 things that we usually say it's important for family members to tell them before they pass. Number 1, say thank you for all that they have done for us. Number 2, say sorry. Say sorry for the wrongs that we have done to them. Okay. Say bye-bye, say final goodbye, okay? And say that I love you. I love you, but I can't be there. I think these are very powerful words to help them understand that we are really trying very much to be there, but we can't. And we really, really hope that, you will be peaceful and comfortable without us. That's something that's important. But really, I really don't want to come to that, and I really hope to avert this situation for the next 1 year, because I expect that my department's business is going to be very good. I do not want that kind of business. Okay, please consider what you can do to prevent this from happening to yourself or your family.
Dr. Neo, the next question, how does a new variant come about? Is there any way to prevent new strains that are more virulent from appearing, or maybe detecting them earlier?
So if you look at and this is also the same reason why WHO objects to governments giving boosters to their citizens. This is when there is a difference in opinion between governments looking after their own citizens and their own interests versus WHO. The Alpha variant emerged when UK had their worst outbreak last year, and the Gamma variant in Brazil, you recall Brazil had a very bad outbreak late last year, and same thing in South Africa. Okay, so when there are a lot of COVID circulating, some patients for various reasons. Okay, so we know a few things now. There is a report in New England Journal of Medicine that shows that patients who have very poor immunity, I recall it's a transplant patient. The first COVID virus is actually not a variant. Okay, but over 2 to 3 months, this patient developed all the resistance that make it an Alpha variant. Okay, so and in South Africa, they all shown that HIV patients untreated can also have this problem, because in Africa, HIV patients, some of them don't get treated, whereas here everyone gets treated. Okay, so when there's a lot of COVID patients around, some of them have poor immunity, and this is people like transplant, cancer on treatment. These are not all people with diabetes, hypertension. Okay, diabetes, hypertension, lung disease, kidney disease, they are not considered that sort of poor immunity. We're talking about cancer patient, transplant patients. Okay, then it allows the virus to mutate slowly, and some of this virus, the mutations, the mutants are more transmissible, and then they take over the epidemic. So we can see that happening very quickly. Delta taking over, everywhere in US, UK, in South Africa. So that's why WHO suggests that don't give the third dose yet, vaccinate the rest of the world. That is what WHO says that. Okay, so the less COVID around, the less likely there'll be the next strain.
Thank you, Professor Lai. Related question, if new strains were to continue to appear and wreak havoc, it seems that there will be no end to this pandemic. Mass vaccination was supposed to be the answer, but almost now, 9 months after vaccines are available in Singapore, it seems we are worse off compared to last year. So what would be the real exit strategy from this pandemic?
I'm not sure that I agree with that statement. The rest of the world, mainly the developing countries, okay, South America, Africa, most part of Asia are not very well vaccinated. Europe, North America, us, and China are well vaccinated. Okay, we're talking about 60-70%. Okay, and the problem now in these countries is pandemic of the unvaccinated from Delta. Okay, so if we manage to vaccinate everyone, and that's the main reason why I want to talk to you today. If you're unvaccinated, get vaccinated. I don't care if you take Pfizer, Moderna, Sinopharm. If your family, your relatives, your neighbors are not vaccinated, tell them to get vaccinated. That's how we exit. You know why? Because if you're vaccinated and you get COVID, your chance of getting sick is a lot less. And when the government sees that, when the hospitals are not full, when deaths are not skyrocketing, then governments will be more willing to open up. Okay, and can we shut down forever? We just have to look at Australia, New Zealand, even China. Delta just spread. China can do it. They shut down more than 20 provinces and cities, and they managed to suppress Delta. Okay, but cases are increasing in Sydney, increasing in New Zealand. Delta. With Delta, it becomes very difficult. But vaccines still will allow us. That's why I said in my slides, 2 ways to get out of this. Wear the mask. Okay, a lot of people don't wear it properly. I'm one of those kaypoh people tell people you're not wearing your mask properly, and they stare at me. And get vaccinated. At the moment, I'm worried about that 70-year-olds and above. Okay, because the 87% one dose is not good enough. Okay, how good? Ideally, everyone, but at least 95% or not. We're not talking about herd immunity here. We're talking about if you get infected, you will not suffer. At least you won't suffer too much. Okay, and with Delta, I'm not talking about herd immunity anymore. I'm talking about reducing your risk of severe COVID with vaccination.
Thank you very much. There's one question that says, what if the virus transmits to animals? Do we have any contingency plan for that?
So there is some European countries, when the minks got COVID, they slaughtered all the minks. At the moment, transmission, there was a one-off event last year. At the moment, the virus can transmit to some animals, but it's not efficient. And it is still not a major problem yet. And the animal doctors, so they are veterinarians, they are definitely watching it. But I'm not an animal doctor. I'm a human doctor. Okay, so I'm not even sure our vaccine will work in that situations. But at this stage, and I heard of Russia vaccinating some of the farm animals. But at the moment, there's no evidence of widespread animal infections with COVID.
Thank you very much. We still have a lot of questions, but unfortunately, we have overrun our time. So
maybe we can go until 4:45. I'm okay to continue for a few more minutes.
Oh, thank you very much, Professor Lai. So the next question. Professor, there is some literature that Moderna is more effective against Delta. Will MOH be looking into this, providing the booster shots for those who have been inoculated with Pfizer?
So one of this piece of information came from the Mayo Clinic in US. And when I studied the paper, it is quite hard to understand. I mean, I understand it, but it is quite a complex paper. And essentially, Pfizer is better than Moderna in June, and then Moderna is better than Pfizer in July, and then they rush out the paper. And someone also asked in the chat box earlier about another UK study that suggests that Pfizer is better than AstraZeneca in the first few months, and then at some months, AstraZeneca is better than Pfizer. Once again, it's based on 1 month. I think that needs to be a more careful follow-up of this data, because there are also other studies from UK, from Canada, from Israel that don't show that. I mean, there's no AstraZeneca in Israel, but AstraZeneca in UK. So while there's that study from UK that shows that, the others from UK that doesn't show that. So at this stage, we are studying it. Pfizer and Moderna are still considered roughly equivalent. Then AstraZeneca, Janssen, Sinopharm as the second rank, followed by Sinovac. But if there is great evidence that Moderna is better, then it's for the government to decide what to do.
There's a question to ask Professor Lai, why not make the vaccine mandatory if vaccine is the only way to prevent variants?
One of the reasons mentioned is really about that the vaccine has not been fully approved. So in the US, they have emergency authorization. Here is called PSAR, PSAR. I don't quite understand what that legal implication is, but US just fully approved Pfizer, and I'm sure Moderna will happen soon. And I suspect at some point HSA will also review Pfizer and Moderna, but I'm not aware of what is going on. But the other thing is, how do you mandate it, right? If someone really refuses it, can you go up to them and jab them? You can't, right? So what the government doing currently is kind of, if you want the convenience of dining out with your family, of going to the cinema, of going to the fitness center, you get vaccinated. And at work, if you don't want to be struck more often, you get vaccinated. And seriously, it's really not about inconvenience. You're protecting yourself and your family. Delta is no play, okay? When I first came across Delta in April, I was in NCID working. I became a lot more religious with my mask. And we won the world. We produced our analysis very quickly, submitted it we put it online, and as a result, WHO and USCC picked it up. Okay, we saw Delta before UK, and we won the world. So, so I hope that answers your question.
Thank you. A related question: what are the chances of getting infected by people taking walks in the parks without mask on?
Well, if you're alone in the park, I would say it's low, but you will be breaking a law, unfortunately. So I try to answer this question by checking MOH. MOH says walking does not exempt you from wearing the mask. If you are skating, cycling, running, yes. But walking, you must still wear the mask. It makes sense, right? I walk to MRT, I wear the mask. Suddenly, I put on some shorts and singlets, and I walk as exercise, I don't put on the mask. But unfortunately, some of us will know on long weekends, the parks are busier than the malls, and then your risk will be high. Okay, and luckily I stay clear of the busy parks, so basically it's people. Okay, so don't get caught without the mask in the open area unless you are exercising. So that's one part. But if you ask me the questions, if there's no one in the park don't wear masks, would you catch COVID? Of course, no, because you need transmission between people.
Thank you. There's a question. Some people prefer to wait for Novavax. What's your view, please?
Novavax is, when we evaluated vaccines, is very, very promising. We really like it because it produces great antibodies. But unfortunately, it has problem with manufacturing and getting approval. We read recently that there's some issue with US FDA. So the Minister Ong still said it will come before the end of the year. I don't have particular information, but it's a good vaccine if it comes.
Thank you very much. So I related the follow-up question from the earlier question that there are more and more people now taking walks without mask on. Do we have the right to tell them to put the mask on?
So it is not. I think everyone has a as a good citizen, you can definitely remind people. I've definitely done that, in a friendly manner. But if you are a bit of a shy person, it's probably not a good idea because the likelihood of these people being rude to you is quite high. You realize that after the last P2HA, government enforcement is a lot higher now. We see restaurants getting fined. We see KTV getting shut down. So I think the government knows that the Delta is bad and it's definitely stepping up enforcement. So I do that sometimes. I remind my neighbors, I remind people in the parks, but at the same time, your likelihood of being ignored or being scolded is quite high. So yes, you can remind them. We're all being good citizens and good member society, but you know, I would rather stay away from them so that I don't get infected.
Thank you. Someone asked, if he has severe numbness, is it okay for him to take the vaccine?
Yes, I don't think the vaccine causes numbness. So, you know, the only reason why you shouldn't take the vaccine really is an allergy to the vaccines. And, you know, most medical problems are not a contraindication.
My 43-year-old son is autistic. He has phobia for needles. Jab is out for him. What are the alternatives for him?
Unfortunately, the current vaccines are all needles. I can tell you that the data for prevention for hydrogen environment is not there. There may be other things later. For example, AstraZeneca just announced that their long-acting antibody may prevent it, but that's not available in Singapore. And one of the antibody company has shown that if you're exposed to a patient with COVID, taking the antibody may also reduce the risk of getting infected. But the vaccines are very expensive. The antibody is very expensive. So at this stage, I think I totally agree. It's very difficult to vaccinate in that setting. You know, it's try to protect him. You know, avoid crowds. It's hard to enforce masks as well, but try to protect. You know, avoid from crowd. If there are visitors, you know, try to. I mean, hard to tell your visitors or your friends to put on a mask, right? But you may have to protect your child who cannot be vaccinated.
Thank you. Maybe just finally, Professor, you mentioned about this ivermectin in your talk, but there are many questions that have come up in the chat about ivermectin, about how it has been used in the US to treat 6,000 patients successfully, and about how in India this has been used quite successfully. So I guess perhaps you could just comment on the effectiveness of ivermectin.
So, you know, there's this group of doctors called the FLCCC. They're not anti-vaccines. They just somehow are fascinated by ivermectin. And then there's this old professor, Borodi, a Polish doctor in Australia, who used to be, who made contribution to medicine, but who has pretty much retired. And somehow they all love ivermectin for reasons I don't know. So there are trials. A lot of the trials of ivermectin came from South America, Bangladesh, India, and many of them are very poorly conducted. Okay, I was an editor and I've handled some of these manuscripts, and they just cannot be published because there's just so much holes in them. Okay, and of the better quality trials that have been done, these are called randomized controlled trials, and people have conducted proper meta-analysis published in reputable journals, and it has shown no effect. Okay, so someone in the chat group says, well, that Egypt study, after you remove it from that meta-analysis, still shows benefit. My question to this person is, why would those scientists who did that meta-analysis not pick up the fake data when a medical student could pick it up? Okay, that tells you about the quality of the meta-analysis done by these people. Okay, and so I trust reputable journals. I trust meta-analysis of randomized controlled trial. Okay, so and we know in medicine we can do meta-analysis. This is combining data from multiple trials, and it's rubbish in, rubbish out. You do meta-analysis on bad data, the information is useless. Okay, and I said to you, why would every reputable government and world body, professional societies advise that ivermectin is not ready to be used except in clinical trials. Okay, what do they hope to achieve? Because if you fall sick, they look after you. Okay, but these people who advise you to take it, they don't have to look after you. Okay, so at this stage, ivermectin should only be used inside a clinical trial, and NIH is doing it. There's a UK trial. There's a large Canada trial that has just been announced, and it shows no benefit. Okay, and there's a scientist that did it said he was threatened. Okay, it is so bad. So the data that's often used is hard for the public to actually recognize good versus bad. The simplest thing is look towards reputable sources like WHO, US CDC, UK Public Health England, Singapore Ministry of Health. Okay, and trust that our governments, our honest government, our doctors do care about us. Okay, and not all these strangers.
Thank you very much, Professor Lai, and thank you very much, Dr. Neo. Unfortunately, we do not have time to carry on. So we have now come to the end of today's webinar. A big thank you again to Professor Lai and Dr. Neo for taking time off your very busy schedule to share on this very pertinent issue and to clear many doubts. Thank you also to all the organizers, to Pa-Auk Meditation Center, Buddhist Fellowship, Dot Connection, Palelai Buddhist Temple, and Ruan Buddhist Society. And of course, thank you very much to all of you for joining this webinar. So may everyone be well and happy, healthy and safe. May we all be free from the afflictions of COVID-19. So thank you very much once again, and a very good evening to everyone. Stay safe and stay healthy. Thank you very much.